Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Tainatongo. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning. Good morning. What's your problem? Well, doctor, I have intolerance to allergies, inhalant and environmental allergies. What's your age? 36. Okay, do you get any kind of reactions like an itchy rash, throat or tongue swelling, shortness of breath, vomiting, lightheadedness, and low blood pressure? Clinically, these symptoms show the presence of anaphylaxis. No, doctor. Or else, do you get itchy red welts called angioedema that develop on your skin? No, doctor. Are you taking any medication for allergies? No, doctor. May I know your past medical history? 6 months back, when I was under dialysis due to renal failure, I had an acute event of perioral swelling, etiology uncertain. The diagnosis results showed that the allergic reaction was due to Keflex that was used to treat a cellulitis dialysis shunt infection. What medications are you taking now? I am taking Atenolol for controlling my blood pressure, sodium bicarbonate, Lovatsa, and Dialovite. I didn't have any other issues upon my treatment and discharge. That included corticosteroid therapy and antihistamine therapy and monitoring. What were the surgeries performed? Perm cath insertion 3 times in peritoneal dialysis. Are you allergic to any medications? Yes, heparin causes thrombocytopenia. Do you drink or smoke? No, doctor. May I know your family history of diseases? My family members have severe heart disease, carcinoma, and food allergies. Well, your test report shows your blood pressure is 128/78, pulse 70, temperature is 97.8, weight is 207 pounds, and height is 5 feet 7 inches. I suspect you have developed acute anaphylaxis. I would suggest you to go for a radioallergosorbent test, a blood test using radioimmunoassay test to investigate specific Ige antibodies to determine the substances the subject is allergic to. I shall recommend further treatment and medications upon the test results. If the test report shows any specific food or inhalant allergen that is found to be quite high on the sensitivity scale, I would likely recommend that you avoid the offending agent. Right now, I would recommend you to stop further usage of cephalosporin antibiotics, which may be the cause of your allergic reaction, and I would consider your case as an allergy. Being on Atenolol, it would be very difficult to treat acute anaphylaxis. I am prescribing an Epipen in the event of acute angioedema or allergic reaction or sensation of impeding allergic reaction, and you have to proceed directly to the emergency room for further evaluation and treatment recommendations after the administration of an Epipen.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Morning, I suppose you're George?
Yes, and I believe you're Dr. Mark?
Oh, yes, I am. What brings you here today?
Well, I'm having this redness in my, in the white part of my eye, actually.
All right.
I think, I don't know what it's called. Is it called the conjunctiva or something? Mm-hmm. It's quite swollen, and,
I can see that,
yeah. I've been having more tears than usual. It's, more than tears, I think it's, sometimes I can feel that it's sort of like a yellow kind of discharge.
Yellow?
Yeah. And it crusts over the eyelashes, and, when I go to sleep, it's not, during the daytime, it's not really bad, but when I go to sleep and I wake up, you can see that, it's quite thick.
Do you have any particular sensations there?
It's quite itchy, and I feel sometimes burning, in the eyes, and I'm not sure it's because of this discharges or whether anything else is happening. I feel like my vision is quite blurred. I believe the sensitivity to the light has changed as well. How do I call it? It's like stubby.
Stubby.
Yeah. And I just don't have anything else, just these things, and I have other allergies and everything, but I don't know whether it is associated with it.
All right. Allergies, you said?
Yeah. I'm allergic to pollen.
Dust?
Not very much. It's hard to, pollen is, it's tested, and, I am positively allergic to pollen.
Okay.
And, sometimes I get common cold and not a lot. So I would love you to do, probably an eye examination, and,
it's just,
yeah.
There is a thorough history collection in the laboratory.
Yeah, no, so I believe I'm going to have to give some blood or something like that.
No, you don't have to.
Yeah.
You can rest assured.
Yeah.
Always do keep the eyes clean, please.
Yeah. I'm pretty, I've had it when I was a child, and, I remember, I washed my, wash the eyes with clean water. I changed the pillowcases every day, morning. And, I think, I have to do until the infection goes away, but, it's not my expertise, it's more of your expertise. So, I do the basic do's and don'ts, and, I don't touch both eyes, or, with the same finger, or, I don't rub.
Right.
I just don't, I don't want to spread it to the other eye as well, so, and hopefully, last time when it happened, the doctor gave me some eye drops, and, it's just the regular things, I believe, but I feel like I'm a bit of a fraud coming in just for a bit. It might be something silly, but,
you did the right thing.
Yeah.
So, I would ask you not to put a patch over the eye.
Yeah.
It might worsen the infection.
Yeah.
And protect the eyes from dirt.
Yeah.
Especially from the irritants you mentioned.
Yeah.
And did I forget to ask you to take enough rest?
Well, I've not been doing much. I started off using, when it went, on the first day, when it happened, I thought, I'd just, look at it, and I don't want this to go bad or something. So I used an over-the-counter eye drop. I tried it to start with, and now my vision is a bit blurry, so I'm not watching TV or anything. I'm just get a bit of rest. And
I'd also ask you to stay away from work for a few days if it's okay.
Well, that's not really a bad thing. If you're happy to give me a sick certificate, I'm physically feeling really good actually, but it's just I don't think it's safe as well. I work in a chemist as well. I'm not a pharmacist actually. I just read scripts and things and assist a pharmacist. So I don't think it's safe enough with this condition. I should work. So And
For that, I'll prescribe you some antihistamines as well.
yeah.
Okay.
Yeah, so I think that'll be good. I'll probably take some rest and, take the medications. And do you want me to see me next week, or just you want to know how it goes, or like?
How about in 4 days' time?
Okay, cool. So I'll try it, and if I can work it out, I'll do it. Great, thanks. Nice meeting you, Doc.
All right. Cool. Yeah.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Okay, afternoon, guys. I'm sorry, it's been a bit of a short notice. We've been having a few incidents of IV Jelco infections. I know it's been a busy week, and we've been in trouble with a lot of things, transition through to the electronic records from paper. But we need to know that documentation is our responsibility. We need to make sure that Jelcos, once you insert them, you need to document it. We need to check on the patient. We need to work as a team. The handover should be precise, and we need to check all these factors. We need to bring down these incidents. We can't allow these to happen. Last year we had a patient died of an infection, so we need to make sure that it doesn't happen again. So that's why I called you guys up. Let's start our day by not killing a patient. How about that?
Question 26. Now read the question.
During your stay, we will work to keep you as comfortable as possible. Unfortunately, it is unrealistic to feel zero pain after surgery. Our goal is to manage your pain at levels allowing you to participate in physical therapy and other activities. We have many tools to attack pain, starting with the peripheral nerve catheter, or PNC, inserted into your operative leg by the anesthesia team. The PNC delivers numbing medication to surround the nerve that supplies feeling to your hip or knee. We supplement the PNC with other medications as needed, either in pill or IV form. One big help in controlling your pain is to keep your new joint active by moving and working with therapy. Lying in bed too long can result in more pain as the joint grows stiff. In addition to pain medication, you will receive a 10-day supply of Lovenox.
Question 27. Now read the question.
Mr. Fernandez is a 52-year-old gentleman who was admitted to the ER last night. He lives with his wife, Judy, and was found down at home. They also noted he had lower extremity swelling for 5 days and was experiencing some shortness of breath and weakness. When they arrived to the emergency room, he was found to be in atrial fibrillation with a rapid ventricular rate between the 150s and 160s. After 2 boluses of diltiazem, he was started on a drip. He has 2 peripheral IVs, an 18 gauge in his left hand and an 18 gauge in his left. Both were started in the emergency room. Mr. Fernandez is a high fall risk because he fell at home. His bed alarm is on at all times and his call bell is within reach.
Mr. Fernandez, since you fell at home, you're considered a high fall risk, so we need to keep the bed alarm on at all times, okay?
Okay.
And if you need any when you get up, you need assistance, so make sure that you call when you're getting out of bed.
I will use this red button on this.
Okay, so we can count on you guys to call when you need help, right? I need to go get report on my other patients, so I'll be back in about 20 minutes. But if you need anything, make sure you call, okay?
Okay, thank you. Sounds great.
You're welcome.
Question 28. Now read the question.
I've been a nurse for about 11 years now. I started off in cardiac, which I loved, but I was working nights and I wasn't in love with that. And then after that, the school where my kids go to school opened up, and so I was a school nurse for several years. And during that time, I just felt like I had a lot of kiddos coming to me with just a variety of issues that were more behavioral issues, such as they were maybe harming themselves in some way, or maybe having some really big anger issues that they did not really know how to cope with or deal with. And I would try to help them as best as I could and get them some community support. But I really felt like I did not have all of the answers that I personally felt like I needed, or I felt like I needed a little more training. So I ended up leaving the school and worked full-time.
Question 29. Now read the question.
It is true that athletes are specializing at a younger age than they did a decade or 2 decades ago. And that does create overuse problems with doing the same repetitive motions year-round, which is why we typically recommend for kids, hey, enjoy everything, be involved in everything, do a lot of different things. There will always be sports that one athlete will excel more at than another, but it's still healthy to be a multi-sport athlete and use different body parts and different mechanisms. And when you're growing and developing, that has a different impact on your body where you have open growth plates versus when you get older and those growth plates close. And if you're doing the same repetitive activity in a specific area with an open growth plate, you can have a problem there.
Question 30. Now read the question.
This is one of our mannequins, the Sim Man Essential. he is capable of being a healthy patient, we can also program in variables on him that cause him to be unhealthy patient as well, because as we know, most of our patient population these days aren't your typical healthy patient. So when we bring the students into the room for the simulation, they are able to do an assessment of listening to heart and lungs on our mannequin. They can do a neurological evaluation of his eyes as well. Shortly thereafter, then, we go ahead and start the anesthetic procedure. So we start by giving him some oxygen by the mask. Obviously, he's still awake at this point in time. And then the students are expected to start the drug administration. And I am on a computer in a different room able to program the drugs that the students are giving. And then the mannequin responds to the drugs by either, going to sleep or getting sleepy, so that the students then can carry on the procedure that's been outlined for them. What's neat about these mannequins, we can mass ventilate them. We can put special airway devices in, like an endotracheal tube. If they don't happen to get the endotracheal tube in the right spot, he has a blue light that'll light up in his mouth to show them the patient is not getting enough oxygen. I'm on the control, and I can make the heart rate and the blood pressure change parameters as well. So it's a learning experience for them, so they can identify maybe they didn't put the endotracheal tube in the right place. He also has IV access, so we can do IV practice on him. We can give the drugs through the IV. That's typically how you do it in the anesthesia.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer, A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Questions 31 to 36. You hear the lecture given by a senior surgeon on the role of diabetes in the end-stage renal disease. You have 90 seconds to read questions 31 to 36. Role of diabetes in the end-stage renal disease. Of late, diabetes has become the primary cause of end-stage renal disease worldwide. This is due to the fact that diabetes, especially diabetes type 2, is increasing. Approximately 45% of new patients receiving dialysis in the U.S. are diabetic. Early diagnosis of diabetes and early intervention are crucial to prevent the progression towards renal failure, seen in a significant percentage of type 2 diabetic patients and in many type 1 diabetics. The presence of microalbuminuria is the early clinical evidence of diabetic neuropathy, defined as the appearance of low but abnormal levels of albumin in the urine. The characteristics of diabetic neuropathy are a decline in glomerular filtration ratio, progressive increase in proteinuria, hypertension, and a high risk of cardiovascular morbidity. Therefore, the evidence of microalbuminuria should trigger diagnosis for possible vascular diseases and aggressive intervention to cope with all cardiovascular risk factors in diabetics type 1 and 2. The natural history of diabetic neuropathy progresses slowly over the years. In type 1 diabetes, microalbuminuria occurs after 5 years, and the end-stage renal disease develops in 50% of type 1 diabetics. Whereas type 2 diabetics has a more variable course. Very few patients with microalbuminuria progress to advanced renal disease. Without intervention, approximately 20% of patients of type 2 diabetes develop an end-stage renal disease. However, due to the increased number of type 2 diabetes patients compared to type 1 diabetes, the maximum number of patients on dialysis are type 2 diabetics. There are many factors which account for the pathophysiological of diabetic neuropathy. Primarily anatomical and structure changes in the kidney result in increased glomerular capillary pressure in diabetes, which is associated with hyperfiltration at the glomerulus. The next factor is the glucose that can increase the formation of advanced glycosylation end products by inversely binding to proteins in kidneys and circulation. Over the years, these formed advanced glycosylation end products, which stimulate the growth in fibrotic factors, contributing to overall renal damage. Thirdly, angiotensin II contributes to the advancement of diabetic neuropathy by narrowing the efferent arteriole in the glomerulus, subsequently resulting in higher glomerular capillary pressures. While diagnosing diabetic neuropathy, early investigation of glucose intolerance in diabetes to distinguish patients who are at risk for developing microalbuminuria is suggested, especially if they have other risks for type 2 diabetes, such as lipid central obesity, abnormalities, or hypertension. Therefore, the investigation of microalbuminuria presence should be performed at diagnosis in patients with type 2 diabetes, whereas in patients with type 1 diabetes, since microalbuminuria rarely occurs with short-term type 1 diabetes, the diagnosis should begin after 5 years of disease. According to the findings, the microvascular complications develop during the prepubertal period of diabetes. Therefore, clinical judgment should be demonstrated when individualizing these suggestions. The object of diabetic neuropathy therapy involves multi-clinical approaches. Tight glycemic control is the keystone in the prevention and management of diabetic neuropathy. The United Kingdom Prospective Diabetes Study and Diabetes Control and Complications Trial have established that an intensive diabetes therapy can considerably decrease the risk of microalbuminuria and neuropathy development. Nonetheless, blood pressure control is another keystone in prevention and treatment, in addition to glycemic control. The significance of blood pressure control, irrespective of what agent is used, cannot be emphasized enough in diabetes, both for slow progression of neuropathy and for preventing cardiovascular morbidity. According to the recent Joint National Committee guidelines, blood pressure in diabetics is reduced to less than 130/80 mmHg. It is very crucial for doctors and patients to understand early on the 3 or more agents. Angiotensin receptor blockers or angiotensin converting enzyme inhibitors are considered first-line agents in patients with concomitant hypertension and diabetes. Diuretics might be added as a second-line agent in many cases after angiotensin blockade in diabetes. Dihydropyridines, a class of calcium channel blockers, may be considered as the third or fourth-line agents in diabetics, only after initiation of angiotensin blockade and diuretics. There are also other non-pharmaceutical suggestions, such as dietary restriction of protein intake, restrictions of protein to 0.8 grams per kilogram weight per day in patients with overt neuropathy, or even 0.6 grams per kilogram weight per day is recommended in the case of declining glomerular filtration ratio. Moreover, it is very essential to stick to a low-sodium diet in diabetic neuropathy, since many diabetics with renal disease are salt-sensitive. Therefore, restricting salt intake will certainly help in reaching blood pressure goals, with secondary benefits of regression of left ventricle hypertrophy, decreased stroke risk, and reduction in proteinuria. A recommended low-sodium diet of 2.3 grams daily in patients with diabetes and either hypertension or proteinuria. Moreover, avoiding nephrotoxin agents, such as radiocontrast media, nonsteroidal anti-inflammatory drugs, is highly recommended. Last but not least, annual diagnosis of microalbuminuria in diabetics will allow the detection of neuropathy at an early stage. Improved glycemic control and intensive antihypertensive treatment will ultimately slow down the progression of diabetic neuropathy.
Now, turn over and look at extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
I'm here with Dr. Jeffrey McLean, who's an expert in neuromuscular disease. Tell us a little bit about your background. How did you become a neuromuscular disease expert?
Well, I started out with my general neurology training, which I did at Wilford Hall Medical Center. And from there, I did a fellowship in neuromuscular medicine before returning to where I am now.
And what's your typical day like? What kinds of patients do you see?
I see a fairly broad mix of patients, but when I'm doing specifically neuromuscular medicine, I do a lot of procedures, electromyography, which is a procedure that we use to help diagnose neuromuscular diseases. The type of patients we see range from patients with neuropathies to patients with muscle diseases that we call myopathies, to patients with disorders of the connection between the nerves and the muscles neuromuscular junction disorders such as myasthenia gravis, to problems with the motor neurons such as ALS or amyotrophic lateral sclerosis.
So a variety of very common diseases and some that are more rare and very have very serious prognoses.
Exactly, that's right.
And what is the most exciting new development in your field? Which of those conditions have something new to offer patients who are listening?
I think perhaps the most exciting field where we've seen a lot of attention recently has been ALS, especially with the Ice Bucket Challenge recently that garnered so much public attention, so much public excitement. That excitement has transferred into more attention, more funding for more research, things that are looking at improving our understanding of the genetics that play into ALS, where there's a lot of work being done trying to find biomarkers, so things that can be tested easily to more readily diagnose ALS and understand how it progresses in a particular patient. All these things ultimately help us find and research possible treatments that in the end are hopefully will lead us to things that will really benefit patients.
And up until now, there really has not been a great deal to offer an ALS patient. What do you do today?
Right now, what we're focused on is improving the quality of life while people are dealing with this disease. And that's an important thing for both patients and physicians to understand, that while we don't have a cure, there are many things that can be done to significantly improve the quality of life for our patients. So things like help with communication, because many of the patients lose the ability to control their voice and control their speaking. So we can do things to help them communicate as that occurs. Things like assistance with nutrition, because they have difficulty swallowing and eating. So helping them with that. One of the big and often under-recognized problems with ALS are mood problems that go along with it. Obviously, it's a devastating diagnosis, and the social support is very important, that we offer that to our patients to make sure that their quality of life is as high as possible while dealing with this.
And on the other end of the spectrum, we have neuropathies for which we can offer a whole variety of treatments. Is there anything new or exciting for the patient with diabetes or someone else with neuropathy to consider?
Well, again, there's a lot of new research going on. There's a lot of exciting work in terms of trying to find ways to treat the often painful diabetic neuropathies. There are already some drugs currently available that many patients will be familiar with, and as time goes forward, we hope to increase the number of drugs that are available to make them more effective with fewer side effects. So hopefully that will be very soon on the horizon.